On January 4, 2016, we were called to a patient found by a passing ambulance crew on the Bruce Highway with the intent to kill herself. The patient made numerous attempts to be run over by passing vehicles without success. She was originally reluctant to provide information, then later disclosed that she was very distressed about recent family events and had recently given birth. On arrival at hospital, the patient stated that after her last 3 children, she had postnatal depression. The patient was admitted to hospital and an EEO was filed. The primary officer on the case spoke to the patient in a calm and understanding manner, reinforcing to the patient that we were there for her well-being and was careful not to use any language or tone of voice that could be considered as judgmental. This case has posed many questions such as what is the correct way to approach a patient like this and what is the best way to assess them. In CSB332, we looked over what was required if an EEO had to be processed for the patient, which gave me some indication what was going to happen to the patient when we arrived at hospital. Also, my knowledge of the QAS CPM mental health assessment allowed me to understand what my mentor was looking for when observing the patient. Observing this case assisted me to understand how this theory would be used in a real-life case. However, I feel as though to be a better paramedic, I need to understand more about various types of mental illness rather than mental health as a whole. In this case, depression was a key factor in the way the patient was presenting. As there are a variety of different presentations of depression, there have been many debates on what actually causes depression, whether it is an imbalance of chemicals in the brain, lifestyle choices, or life events. Bondi B. 2002 in the Dialogues in Clinical Neuroscience journal points at depletion of neurotransmitters such as noradrenaline, serotonin, and dopamine, which are said to be key in the control of mood and emotional behavior, as one of the main causes of depression. However, Hazel G. 2010 in the World Psychiatry Journal states that although depletion of any of these transmitters can lead to depression, there is no conclusive evidence that it is the sole cause of depression in all patients. Lifestyle choices such as excessive alcohol consumption, drugs, lack of sleep, and poor diet and exercise are aspects that may lead to depression, as they cause abnormalities in brain chemicals. Research by Burns L. 2002 in the Drug and Alcohol Dependence Journal states that those who consume large amounts of alcohol are 4 times more likely to suffer from depression. This is because alcohol has depressant properties and when consumed at high levels can cause long-term damage to the neurotransmitters in the brain, as outlined by Dunn and D. and Patanti H. 2011 in the Psychiatric Times. This is highly relevant to the case as the patient had drunk some alcohol prior to her episode. Big life events can also lead to depression. Kendler, Kowalski, and Prescott 2006 in the American Journal of Psychiatry state that due to their research on how stressful life events can cause depression over a 1-year period, they can conclusively prove that independent stressful life events were significantly associated with the onset of depression. In this particular case, the patient had a history of mild depression prior to having children, however it became more severe after childbirth. Pregnancy, Birth and Baby 2015 on the healthcare website states that 1 in 7 women in Australia are affected by postnatal depression every year. According to the Office of Women's Health website 2014, postnatal depression can be caused by a mixture of all the causes mentioned above and can also be due to hormonal changes unique to women during pregnancy. There are many treatments for depression such as counselling, electroconvulsive therapy, and the most common being antidepressant medication. The Beyond Blue website 2015 states, however, that not one of these treatments can be conclusively proven to help everyone. Although in paramedics we are unable to treat these patients, knowing that there are different types of treatment for depression will help in the management of patients until arrival at hospital. The theory behind depression has provided me with information to understand that depression has multiple presentations and that there are many ways to treat depression. The QAS CPM 2015 has provided paramedics with a series of questions for assessing suicide risks for patients. However, Shahab and R. 2009 in Challenges in Paramedic Practice, Chapter 7, states that because paramedics have limited time with the patient, building a rapport and understanding to what degree the patient deals with depression and their current treatments is main priority. From these resources, I can now understand how my mentor combined the suicide risk questions with the mental health assessment learned in CSB 332 to complete a thorough assessment of the patient. From observing this case, I have been able to view the situation from both the paramedic and patient's perspective. Due to the patient's early reluctance to provide information, it was clear that she viewed the paramedics as authority figures who weren't there to help her. Whereas the paramedics approached the situation wanting to help her the best they could. Due to these observations, in the future, if a patient is refusing help, I'll be sure to listen to their reasons why and address their concerns, while also reassuring them that I'm there for their welfare. Through my experience on road and my research into depression, I now believe that in the future I will aim to use my knowledge and the help provided by the QAS to tailor my approach to the individual, not the illness.